Welcome to today's ISCWA webinar on patient-reported outcomes from a research tool to quality improvement. This webinar will address patient-reported outcomes that have been around for decades but used primarily as research tools to follow up patients in clinical trials. With the converge of trends such as patient-centered care, value-based healthcare, and comparative effectiveness, recent years have brought about a shift for using patient-reported outcomes at the clinical level aimed at three groups of stakeholders: patients, clinicians, and quality managers. This webinar will explore what patient-reported outcomes are, provide examples of successful clinical program implemented, and how they can transform healthcare services provided. I would like to welcome our today's presenter, Dr. Zimlichman, who is an internal medicine physician currently serving as Deputy Director General and Chief Quality Officer at Sheba Medical Center, Israel's largest hospital. Prior to this, Dr. Zimlichman has held the position of lead researcher at Partners Healthcare Clinical Affairs Department in Boston, where he was involved in the efforts to bring about a strategic care redesign initiative. In that capacity, Dr. Zimlichman has established for Partners Healthcare a program for collecting and reporting patient-reported outcomes across the continuum of care, a program that have won an international appraisal. Dr. Zimlichman is also conducting research on implementing technology to improve healthcare quality and patient safety at Brigham and Women's Hospital at Harvard Medical School, affiliated Center for Patient Safety Research and Practice. Dr. Zimlichman served as an advisor to the Office of National Coordinator for Healthcare Information Technology in U.S. Department of Health and Human Services. Just to remind you all that today's presentation will take approximately 45 minutes and we will leave 10-15 minutes at the end for any questions that you may have. Please type your questions in the chat or question box provided and they will be posed to Dr. Zimlichman at the end of his session. Please enjoy the presentation, and over to you, Dr. Zimlichman.
Thank you very much, Juliana. And I want to thank ISCWA, of course, for this opportunity to talk with you about patient-reported outcomes, which I think is an exciting new field, which we're all going to be experiencing more in the next upcoming years. So without further ado, we could start with our presentation. And basically what I'll start with is this new healthcare paradigm shift we're seeing. And we're hearing all these new terms popping up, maximizing value, which I'll talk about in a few more seconds, and patient-centered care, of course, centering on patients' needs, comparative effectiveness, trying to find out what works and what doesn't, what works better than others, and personalized medicine, of course, trying to treat a specific patient according to what his needs are on many levels. When we talk about the patient is interested in receiving the best achievable and sustainable outcomes for himself. That's his first and foremost priority. When we talk about the provider is interested in achieving affordable outcomes that matter to patients across the continuum of care. These are the new healthcare reforms we're seeing in the US and across much of the world. Taking all of this together will be the topic of our presentation in the next 45 minutes. And we start with value, and we start with Professor Michael Porter from Harvard Business School, which I'm certain some of you have heard his name and some of his teachings. And Porter is saying the central goal in healthcare must be value for patients, not access, volume, convenience, or cost containment. And if we focus on value for patients, that's where we need to put our resources. And basically Porter is also saying that healthcare systems need to be redesigned so that they dramatically improve patient value. If we focus on value for patients, if we focus on patients and what matters to them, then we can dramatically improve patient value. So back to the slide, when we talk about integrating measures that matter to patients, we've done some research around this to see what are the different measures that matter to patients. And these are the 5 elements we've come up with. Some of these are tracked routinely in most of our countries, like clinical outcomes. We track complications. We sometimes track mortality. We track accessibility. We can track cost. We sometimes do that. We track experience, whether it's through patient satisfaction surveys or other tools. But we seldom measure functional status, which is really what the patient many times is interested in. Physical health, mental health, the perceived well-being, and managing risk status for patients. And this is where we're going to be focusing when we talk about patient-reported outcomes. So Porter has an outcome measure hierarchy, which basically says there are 3 different tiers for outcome measures. Tier 1 is looking at survival, very basic, which is mortality, and degree of health or recovery. So what is our functional status, what is the perceived health benefits, and the perceived well-being for us as a patient. Tier 2 is looking at the short-term outcomes, like time to recovery and return to normal activities, whether it's recovery from a medical procedure, from a disease. We track functional status, both physical and mental. We track perceived well-being. And we look at the disutility of care, which is the complications on the short term. On the longer term, which is tier 3, we look at the sustainability of health or recovery. So what is my functional status on the long term, my perceived health benefit, and my perceived well-being? And similarly also for the long-term consequences of therapy, what is the long-term clinical complications? These are the 3 tiers that Michael Porter talks about. If you'll notice on this slide on the right, we're seeing different colors of text. We're seeing the red and we're seeing the black. Basically, black is what we're all measuring today. We're measuring mortality, we're measuring clinical complications. Sometimes we're measuring long-term clinical complications. But we're not doing a very good job with measuring everything else you see here in red. And that's where patient-reported outcomes is going to take us. So what's the value of surgery for the patient? If we look at it from the patient's perspective, what kind of an advancement in quality of life are we seeing? What kind of gain in quality of life are we seeing from the different procedures, as you see here? And some of these we see a lot of gain, like knee arthroplasty, hip arthroplasty, lumbar surgery. All of these would produce a very high quality of life gain. Some of the others, like cataract surgery, radical prostatectomy, hernia repair, would show smaller quality of life gain. And these are things that the patient is interested in, of course, and this is one way to measure this. So what are outcomes or patient-reported outcomes? So first of all, if we look at the simple definition of patient-reported outcomes, we find that the definition is a questionnaire used in a clinical trial or a clinical setting where the responses are collected directly from the patient. Notice the word clinical trial, and this is where these tools have come from originally. It's also a means of gathering patient views on outcomes. And if we look at patient-reported outcome measures, these describe the use of patient-reported outcome data as quality measures. So we use patient-reported outcomes and we build measures, outcome measures, out of patient-reported outcomes. Now, patient-reported outcomes can be either generic or condition-specific. Now, some of the generic tools have been around for many, many years. We know them from clinical trials, the SF36, the SF12, and some of the others, or the VR12. These have been around since the 1960s and 70s, being used in clinical trials to measure functional status and mental status on patients going through different clinical trials. There are also condition-specific tools, like adult asthma quality of life questionnaire for asthma patients, of course, migraine-specific quality of life for migraine patients, or Seattle angina questionnaire for angina patients, patients with heart disease. All of these are disease-specific and again have been used for many years in clinical trials measuring these specific conditions. Now, only in recent years we've started seeing these tools being put to use for clinical improvement, for quality improvement. And this is the new use we're noticing being done with patient-reported outcomes on a clinical level. And this is what I'm going to be focusing my talk about. So let's jump in and start with the first example, and we'll run through a couple of these. The first one, and maybe the first one that really made big waves, is the Dartmouth Spine Center in Dartmouth-Hitchcock Medical Center in New Hampshire in the United States. We know about Dartmouth-Hitchcock. It's one of the best locations now that really deal with improving quality on many, many levels, but also they've been the pioneers for using patient-reported outcomes on medical practice. And specifically the 3 people you see here, James Weinstein, William Abdu, and Eugene Nelson, who's really been masterminding a lot of the work on patient-reported outcomes in the last 3 years. Now, what they've done in their spine center basically is they had their patients fill out a patient-reported outcome tool, and you see it in front of you, or at least you see the dashboard that represents the scores from this tool. And patients were filling this out in a tablet. You see this in the photo here, in the waiting room. For example, they were asked to fill out where they have pain, as you see here, using the stylus pen on the tablet. And this was visualized for the physician as part of the electronic medical record, as you see on the left side of the screen. The physician could also see the signs of the history and symptoms, any red flags, disability status, functional status, and patient perception, all of these from patient-reported outcomes that were fed into the electronic medical record system. And this is a very initial attempt. This was done around 2006, 2007, when this type of technology was really only beginning. Another way to look at the data was through their website. So the Dartmouth Spine Center has a website where patients can log on and can compare surgical treatment versus non-surgical treatment for patients that have low back pain. And this was tracked using looking at bodily pain, as you see here on this upper graph, and physical function, as you see here on the lower graph. And you could see the surgical, which is in red, is showing different success rate over the years than the non-surgical treatment. Now, this is something patients can use to actually make an informed decision about their care. Should I go through surgery, or should I stay with the traditional non-surgical care? And physicians and patients looking at this data together could make an informed decision, a shared decision on where the patient wants to go on. Another example is the Memorial Sloan Kettering Cancer Center, the Urology Clinic Experience, and this was masterminded by Andrew Vickers, who deals with outcome research. Now, what they've done basically is they've started tracking for patients that have gone through prostate surgery for prostate cancer. They were tracking patient-reported outcomes, specifically looking at incontinence and impotence for patients after prostate surgery.
And patients were reporting using a standardized tool to measure these two complications. And what you could see is on this slide is that for a specific patient, as you see here in this example, we could track across time from the surgery exactly the erectile function and urinary function for a specific patient. And this was done on all the patients going through surgery at Sloan Kettering. Now, what that gave us is another usability, but this time not only from the patient's perspective, but also from the clinician's perspective, attempting to improve performance. And I'm going to the next slide, which basically shows you a graph that physicians at Sloan Kettering, urologists at Sloan Kettering can access, where on this graph, every point here, each blue point on this graph is representing one surgeon, one urologic surgeon that is doing these prostate surgeries. And we see how he's doing on the continent at 1 year versus potent at 1 year on this scale. Now, since every one of these dots is a different physician, these clinicians can look and see how they are comparing to the others, and if others are doing better or worse than what they are doing, and is there anything else they could do differently to prevent these complications from happening. Now, not only looking at complications, but also looking at complications versus recurrence-free. As we know, when we do the surgery for prostate cancer, our goal is to remove all the cancer tissue so that the patient is cancer-free. We don't want to see a recurrence happen. So what we see on this slide is basically measuring the recurrence-free at 2 years from prostate cancer versus potent and continent at 2 years. So without any of these two complications. And again, each dot is a different surgeon, and we could see that there's a big variability between different surgeons on how they're doing on the recurrence rate versus the complication rate, and some are doing better than others. By being able to measure these complications from the patient's perspective and looking at performance level data, we're able to measure and improve our own performance as physicians. And this is another use case for patient-reported outcomes in the real world, which is being carried out. From here, I want to jump on to a third example, which is a national example of PROMS implementation. And this is at the NHS in England. Now, this is the first country in the world to implement a national PROMS program. They've done so since about 2008 when they launched their first pilot. And they're focusing on 4 surgical conditions. They're only doing this on surgical conditions, and they've started with these 4 conditions as you see here. One is total hip replacement, then total knee replacement, varicose veins, and hernia repair. Now, they've chosen to look at 2 different tools, or 2 different types of tools. One is a generic tool which is the EQ5D, also known as the Euroqol, which gives us a generic measure of functional status or quality of life. The second is a condition-specific component, which is relevant and specific for this type of procedure. For the total hip replacement, we use the Oxford Hip Score. The total knee replacement, we use the Oxford Knee Score. And for varicose veins, we use the Aberdeen Varicose Vein Questionnaire. For hernia repair, in the NHS, they've chosen to use only the generic component. So they're tracking these on a national scale for every patient that goes through one of these 4 conditions. Now, looking at the data from 2014, which is the latest data published, we could actually look and see for different patients, different conditions, how patients are doing. So if I look at this graph and I look on the right side, and I'm looking on the percent of patients that have improved their either physical function or symptoms that relate to the specific procedure, we could see that after hip replacement, 89% of patients report improved quality of life and functional status. For knee replacement, 81% report that. For groin hernia repair, 50% report that. And for varicose veins, 53% report that. That already gives us a measure of how much of quality improvement, of quality of life improvement we're getting from these specific 4 conditions. Some of these conditions have actually worsened these measures, as you could see here. Varicose veins, for example, you see here that some patients have worsened their quality of life, similarly for the others, but that's a minor percentage compared to the patients that have improved. And this is looking at unadjusted scores by procedure and measure. How is the NHS following up the patient? So how are they doing this? So the default is mandated methodology includes distributing the survey in the clinic during a pre-op appointment. So the patient, before the procedure, comes to the pre-op clinic, and in that point in time, he receives the questionnaires to fill out, and these questionnaires are basically then fed into the electronic system that goes centrally into NHS. This is the pre-surgical. Then the patients will complete the post-op survey upon returning to the clinic. If the patient is not reached during the post-op appointment, then a letter is sent to the patient at his home. Now, this is only looking at the post-op clinic, so basically a month following procedure. We don't have long-term follow-up of our patients in the NHS example. And also, it is up to the provider to make sure that a representative population is reached, which is not an easy task, and all patients receive the survey after qualifying for the procedure, of course. Now, what's the response rate? At the pilot research carried out at the London School of Hygiene and Tropical Medicine, they've suggested that a patient participation rate of 80% is needed to minimize the risk of data being unrepresentative. And I'll get back to that number later on when I'll talk about our research. But what actually happened? So at least in the initial years, what they found is that the preoperative questionnaires returned a headline participation rate of 70%. That's again for patients filling this out in the pre-op clinic. Problem is that for the post-operative questionnaire, the return rate was only 46%. So if we talk about a threshold we want to reach of 80%, we have an issue there of a smaller sample size that is needed for us to really get a representative sample of the population. And that's one of the major issues with the NHS experience. But of course, doing this on a national scale is very, very challenging to actually get to the 80% mark. So leaving England, we're back in the US now, and we're looking at Partners Healthcare from Boston, the patient-reported outcomes program, which I basically led the pilot for starting for about 2011, a couple of years ago. This was a pioneering attempt by a healthcare system to implement an operational PRO system across the system, including collecting data through a multimodal approach, which I'll talk about, then reporting the measures to providers and patients, and using the data as quality metrics on the physician, clinic, hospital, and system level. It's one of the first attempts in the world to really try a very comprehensive approach to patient-reported outcomes and using patient-reported outcomes as a means to redesign care so that care is more patient-centered and is focused on outcomes. And these were some of the questions we were asking ourselves. So initially, what should we be asking patients? Should we be asking generic questions or disease-specific? And if you remember, we made that distinction, and the NHS has decided to look at both, and this is actually something that we have decided to do also. What conditions would best fit PROMs? Surgical procedures versus chronic conditions. Again, would this work similarly for CABG as it does for diabetes, or maybe it won't? This was one of the questions we wanted to answer. How or when do we collect the data? Do we collect it on paper versus electronic? Do we do this at home versus on site, like the NHS chose to do it? Do we do it by a visit, or do we do it as a time-oriented, which means every 1 month, 2 months, 3 months, we send the questionnaire in a specific mode to the patient to be filled out, or do we do this whenever the patient comes into the clinic? How do we get participants to play along? Unlike patient satisfaction data, where response rates are generally in around 10 to 20%, we want to get much higher on this. We've mentioned the 80% mark. 60 to 70% might do the job also, but still it's much higher than what we expect to get with patient satisfaction surveys. And finally, how do we get clinicians to play along, which we learned was not an easy fit. It's sometimes even more challenging than getting patients to play along. So a couple of key conclusions. One of them is to make patient-reported outcomes instruments actionable for care redesign. They need to include both a generic functional or mental status tool as well as disease-specific. And again, this is the same conclusion that the NHS has reached when they launched their program, and it's a very important one. Secondly, to ensure patient-reported outcomes would be used to improve care on both a patient-specific level and a population level, a response rate of 60 to 70% needs to be achieved. NHS said 80%. Our research has basically showed this to actually be slightly lower than that, but again, 60 to 70% is still very challenging. Then a multimodal electronic data capture approach should be utilized that would allow for near real-time reporting and also trying to get as many patients on board as possible. If we work only electronically, we might be missing on a large population, which are patients that are not computer savvy, are not using computers or smartphones, and so we have to have a couple of modes to reach the patients, and then have the patient choose which mode best suits him. Then providers need to be able to act proactively on trends of PROMS data, so eventually data needs to be integrated into the electronic records. If the PROMS data is not in the electronic record, providers won't use it, and that's a critical step in making this program work. Then patients should have access to patient-reported outcomes data, and that should be done through patient portals so that they feel they are getting value for reporting. It's not that we're reporting on one end, but we're getting feedback on the other end, and we're seeing how we're doing compared to time and compared to other patients like us. And this will, of course, improve compliance and contribute to patient activation. And finally, patient-reported outcome data integrated with other value metrics needs to play an important role in evaluating and comparing treatment modalities and services. So it's not only using it on a patient level, but using it as quality metrics to redesign care, to improve care, and to drive continuous improvement. Now we looked at different technology applications, patient portals. How do we reach the patient? Interactive voice response, which is what we use on the telephone when we are talking to a computer and the computer recognizes our voice. Human operators, which is widely used, but also is more challenging. It's more expensive. Email, mobile phone applications, which are becoming more popular. Kiosks and tablets in the clinic. Or maybe we should revert back to paper and use just paper questionnaires. We looked at all of these applications, looked at the pros and cons. I won't go through this now, but of course they all carry advantages and disadvantages. And then we finally came up with this model, which basically says, these are the modalities we offer patients to use and report the data through. Initially, we approach every patient through a tablet in the waiting room when the patient comes to the clinic. We talk with the patient about the program. We tell the patient what's in it for him and why it's important for him to give us this type of data. And we say usually, it's like the physician is asking you about your symptoms. You would never think about not answering a physician when he's asking you. These are the same type of importance of data. This type of data is clinical data. It goes into the electronic record, and it will drive your care. So it's very important for us that you give us as much as accurate information as possible. So tablets is one way to do this, but then it has to expand across time because we want to follow up patients as we move away from the procedure that was done. And this could be done through patient portal on the computer and the internet. It could be done through human operators, but it could be done through interactive voice response, as I mentioned. And it could be done through mobile phone applications. And each patient would choose a different modality that best suits him. It might be a mobile phone application for somebody who's on the go, might be a patient portal at home on your personal computer, and it might be just using a phone operator because you're not technology savvy enough to use any of the other modes. You have to provide all of these options. All of that data, regardless of where it comes from, comes into a central database and drives the reporting to providers, to patients, to quality managers. All of these three are critical in making the program work. This is an example of a tool template we've designed for CABG. So what you see here is the pre-procedure and post-procedure tools that we used. We used a questionnaire called the Promise 10 from the Promise Initiative, which is an NIH-backed initiative, federal initiative in the US, which if you've not heard about, I urge you to log online, go to the Promise website, look at the tools. They're free to use right now, and they have a lot of tools up there that you could just choose from. This measures functional status both on a physical level and a mental level using only 10 questions. It's called the Promise 10 Global Tool. Then we had 6 questions talking about symptoms, which specifically for CABG were dyspnea, shortness of breath, and chest pain. We had questions on perceived health benefits post-procedure, and we had one health utility question, which is the famous question asking the patient from 0 to 100, how would you rate your own health? And we wanted to see that change pre-procedure, post-procedure, and then on follow-up. As you can see, we had 17 questions in total pre-procedure, 21 questions in total post-procedure, and it took the patient less than 5 minutes to complete. And this is critical. If you have too long of a tool, it would take the patient too long, you would lose interest, and you would get your response rates down. To get a high response rate, you want to keep it as simple as possible. 20 questions, 25 questions, maybe 30 tops is what you want to be using. As I've said, we've used tablets. We had a tablet interface for these questions at the clinic. As you can see here, one of the examples from the Promise 10 questionnaire, from the shortness of breath questionnaire. You could toggle through questions, go to the previous question, the next question. You could decrease font or increase font if you have any issues with seeing the text. You could toggle between English and Spanish versions. And as you could see, it's very easy to click on the tablet, and we had a lot of experience using tablets, and it was generally a very positive experience. Patients really love using tablets in the waiting rooms. Even elderly patients that are not used to using it were very quick to handle it just like any other person. And then one of the key issues we were working a lot to implement was generating the reports. As you see here an example of a report for the cardiac surgery patients. And the same report was being delivered to the patient and to the clinician. So the clinicians were seeing the report through the EMR as a PDF, and the patients were seeing the report through their patient portal, again, as a PDF file. It's important that they both look at the same one because they're going to be talking and referencing to this report together. It's going to be a joint effort by both the clinician and the patient for shared decision-making, goal setting, and everything else we'll be talking about. So for the patients to feed forward their data across the continuum of care, they're going to need feedback. And that feedback, we were talking about 3 elements. First is the real-time automated reports. That report you've just seen, the PDF report, has to be real-time so that patients see, once they fill this out, they see how they're measuring across time and how they're measuring compared to others. That gives them huge motivation to fill this out again the next time they're being approached. Then the second thing is discussion with clinicians. The patient wants to discuss this with the clinician. And I was usually giving this example. If I go into the room and with the patient and with the physician, and the physician is not talking about Crohn's with me, and I ask the physician as a patient, why are my scores looking like this? And the physician says, well, forget about this. These patient-reported outcomes are not meaningful. If that happens once, then we're going to lose that patient, and we're never going to get him to report any more patient-reported outcome data in the future. So the patient and physician need to talk about patient-reported outcomes. It has to be part of the discussion. And then PRO dashboards for patients. The patients want to be able to look through the patient portal, not just on their measures, but also on how others are doing for conditions specifically that they're thinking about going through. If the patient is considering going through a hip replacement surgery, he could log on the internet and see how other patients are doing that have gone through this type of surgery and then make an informed decision. So we've developed this PRO conceptual framework for implementation, which basically answers to the challenge of getting the staff and specifically the physicians engaged in patient-reported outcomes. That's been a major barrier to implementing patient-reported outcomes in a clinical level. And we start with the development phase. We start with clinical leadership buy-in, as we start with any cultural change we do. But then we start working with the clinicians on the tool design. What are we going to be asking our patients? Defining target populations, resolving clinic-specific workflow issues, and implementing this into the IT. And as for example, if I talk about clinic-specific workflow issues, and you could able to see this here, I really want to track and map what patients are going through when they come to the clinic, and then decide where I want to introduce the patient-reported outcome tablets, and when I want to introduce any discussions I want to have, whether it's with the physician, the nurse, or any other care manager that we have on the team. So that mapping is critical to making this work. And then the IT implementation issues in terms of infrastructure. Are we talking about tablets? Are we talking about kiosks? What's the Wi-Fi coverage in my clinic if I'm talking about tablets? EMR compatibility, as I've said, we want that information to stream into your EMR. Is it a PRO-enabled EMR, like some of the new EMRs? Epic, for instance, is doing a good job with integrating patient-reported outcomes into the Epic EMR system. We want to identify target patients. So how do we link this to the scheduling system? And how do I identify the patient that the patient is coming in is going through this specific type of surgery, and we need to collect the patient-reported outcome from a specific tool from that patient? That needs to happen automatic. How do I link this automatically to our scheduling system is one of the major issues we had to deal with. And then following up patients, how do I follow up after he leaves the clinic? Mobile health applications, patient portals, all of that is technology I'm going to need to think about. So this is where we need to identify the real incentive. Why should clinicians work on this? If I use quality improvement, will that be enough for this specific clinic? Maybe I need to bring up research, because this would produce a lot of research data. We know many clinicians, many physicians are being motivated by research, so that could be a motivating factor. And again, I want to involve the staff in the development process, and that's critical, of course. Then we're starting a pilot phase, which we basically for that identify clinical champions. We provide continuous usability data, which I'll show you in a second, clinical decision pathways, and we need to decide about alert thresholds and mechanism. So for instance, if we want to talk about providing continuous usability, this is an example of a report we provided as partners once a week for all our clinics, which basically said how many patients have filled this out, what's the response rate, how many of them have actually followed up also. And this is important for us to really know where we are and what we need to improve. For clinical decision pathways, what do I, as a clinician, need to do if something pops up on a patient-reported outcome measure? So if the patient is reporting pain, if the patient is reporting fatigue, vision problems, sleep problems, difficulty walking, what do I need to do? What's the possible action steps I need to take? If we don't determine this in advance, then clinicians would say, no, I don't really know how to deal with this. I don't really know what to do when a patient is slowly decreasing on his mental status score or his physical status score. So this is something that has to be done in advance or as we start our pilot. So this has to be discussed in staff meetings. We have to develop case studies of where this helped, and then show these case studies, show them around, between different clinics for different clinicians, and we need to gradually build the physician buy-in. It won't happen overnight. It'll happen physician by physician. But if you work along these steps that I've mentioned here, there's a good possibility that this would work. And then once the pilot works, we start rolling out, either on a system-wide or on a smaller scale. And this is where we need to start thinking about turning patient-reported outcomes into patient-reported outcome measures, quality metrics. This is where we want to see how do we use it to enhance value to patients and clinicians, use it for population health, and use it for benchmarking within and external of my organization. So to enhance value to patients and clinicians, these are the things that I could use prompts for. For patients, public reporting. Patients want to know, how is my institution doing in a specific procedure? What % of my patients actually have their pain levels go down after hip replacement? For patient activation, we use it for shared decision making. Clinician and patient together are making decisions based on informed data. We want to set goals together, goal-oriented patient care. So if I'm doing X, I'm getting a score for an X on my functional status, where do I want to be a year from now on my functional status? And then if I track that and measure functional status, I can see where I am in a year from now. So that's one of the uses for patient-reported outcomes. We want to integrate this into how is your health report card, which basically talks about all the health issues that are important to patients. Prompts need to be a part of that report card. And it's going to be a language spoken in the virtual communities of patients. Patients are going to talk in virtual communities, and they're going to share how they're doing on patient-reported outcomes. Now, for providers, we've talked about this. Care redesign needs to happen according to how we're doing with patient-reported outcomes. We want to look at comparative effectiveness and efficiency, both from a research level, but also from real-life data. What is working better than others? For a patient with low back pain, for this specific patient, should I offer him surgery or should I offer him non-surgical treatment? Patient-generated electronic data. Can I use this platform to take information from my patients, intake from my patients, that's going to be driven automatically into the electronic medical record and save me some time as a provider? That's also an incentive for providers to have this system work. And then, of course, clinical research, as I've mentioned. And if I want to talk about benchmarking, which is critical here, there are specific collaboratives that have already started to emerge. ICHOM, the International Consortium for Health Outcome Measurement, is one of them, being run from Boston. The Patient-Reported Outcomes Measure Collaborative, which I was one of the founders of, which has Cleveland Clinic, Partners Healthcare, Carolina Health, Sheba Medical Center, St. Antonius in the Netherlands, and now all these steps and getting to the system-wide rollout. Again, this is where we want to be. This is where I think we're going to start seeing organization be in the next 5 to 10 years. And this is repeating some of what I've said. Really getting to the care redesign, we need to have patients have informed decision making and receiving care that is patient-centered. Providers have better assessment of patients' global condition and ability to drive care towards patient-centered outcomes. And quality managers are going to support care redesign by using outcomes that matter to patients. And we started with this slide, and I'll end with this slide. We talked about maximizing value, patient-centered care, comparative effectiveness, and personalized medicine. I think, and I would argue, that patient-reported outcomes will play a central role in all of these 4 paradigms that we're seeing in healthcare happen in the last few years. And I've walked us through maximizing value, patient-centered care, of course, using it for comparative effectiveness. And at the end of the day, personalized medicine is not only genetic testing, but it's also being able to track a specific patient and then tailoring the treatment for that specific patient based on his patient-reported outcomes. And I'll end with the story of Ernst Codeman. And Ernst Codeman, who's from Harvard Medical School and then from Mass General, said almost 100 years ago, the common sense notion I propose is that every hospital should follow every patient it treats long enough to determine whether or not the treatment has been successful, and then to inquire, if not, why not, with a view to preventing similar failures in the future. And when Codeman said this almost 100 years ago, many other people did not really understand where this was going. And Ernst Codeman did not get the credit he deserved back at these days. But now when we look back and we read what Ernst Codeman has said back in 1917, we could relate to this and say, you know, we've been missing on this. We haven't been doing this, and we need to be doing this more in the future. And this is where patient-reported outcomes are going to play a major part, preventing similar failures and improving our care to our patients. And I'll end to that, and of course I'll open it to questions if there are any. Thank you very much.
Thank you, Dr. Zimlichman. Thank you for this brilliant presentation, and what a brilliant way to finish your presentation with such a quote. We do have a number of questions, and I suppose we don't have so much time left, so we'll start dealing with them straight away, if you don't mind. So there are a number of questions from Maya Brazis, so I'll pose that one by one. And he is thanking you for this brilliant and excellent presentation, and his question, the first question is as follows: is there evidence of validity and reliability of PRO at individual level?
Well, as we talk about the patient-reported outcome tools, and they are all, or the ones that we use are all validated. As I've said, they have been used for many years in research, and we're all aware of this. And for that, we're seeing that we have that validity information for the tool used for research. We're not seeing yet the validity information we need for the same tools in clinical practice. But I would argue if we use the same tools and we use them in the methodologies in which they were used in the past, we would be seeing this also in clinical practice. And again, there are a couple of experiences around that working in a couple of countries and a couple of institutions, and I'm sure we're going to be seeing some of that data float in the next 2 years. Thank you, Mayor, for this.
Thank you, Dr. Zimlichman. His next question is, how do you resolve conflicting values, such as for prostate cancer, you have mentioned function via reoccurrence. There seems to be completing on your graph. So I suppose the question stands as follows: how do you resolve conflicting values, function via reoccurrence?
It's an excellent question. As you've seen, it's a trade-off, especially with that specific example. We know as you know, as a surgeon, if you want to take out the cancer tissue, the more cancer tissue you take out, you try to minimize the recurrence rate, but the other end, you might injure some nerves and you might get some complications. So it's always a trade-off, and that goes to our performance and our surgical capabilities. And in these specific issues, where to date we've been maybe focusing on the recurrence rates, in many cases we have been focusing on the recurrence rate. We have not been focusing enough on the other side of this, which is what the patient is actually worried about also. The patient is worried about incontinence. The patient is very worried about impotence. He wants to know the trade-off. He wants to know what he's going to get if he goes through this operation, both from the cancer point of view, but from the complication point of view. And because of that, balance, we need to be able to provide our clinicians with that kind of data so that they could work with the data and try to maximize the value for the patient on both of these aspects.
Thank you, Dr. Zimlichman. The next question, again, from Maya Brazis, and it stands as follows: what is the evidence that patients can buy in the PRO data, especially when a small percentage report very poor value?
The buy-in of patients is critical, as I've said. Again, it's a very important point to repeatedly stress out. Patients will fill this out usually pre-procedure and post-procedure. We have a huge issue with having patients reporting this across time. And I think for patient-reported outcomes, really to deliver the value we're talking about and to get to a point where Porter is talking about the sustainability of healthcare as the tier 3 of outcomes, we want to be able to track this across months and maybe years. If a patient is going through cardiac surgery, we want to be able to go back to that patient and after 6 months, after a year, after 2 years, track the complications and track the symptoms and quality of life for that specific patient. The way to do this and to really to get to that level, which again has not been done to date, is to try and follow some of the steps I've outlined here in terms of addressing the patients, showing them the results, showing them how this would be used, seeing how they compare to others, having the clinicians discuss this with the patient, because the patients trust their clinicians, they trust their physician, and the physicians sit down with the reports with them and work this into their shared decision making, work this into goal setting. This is how we're going to start seeing PROMs become a part of our clinical care.
Thank you. The next question is from Tini Masuper, and she is thanking you for this captivating presentation, and she would like you to share your thoughts on experiences on implementation of PRO in limited resource settings, such as where IT infrastructure is very weak?
Right. It's a very important issue. As I've talked about, there are different modalities to capturing the data. The critical piece is capturing the longitudinal data and giving it the attention it deserves on the patient-physician interaction. Now, the attention that it deserves could work in any setting, and sometimes it would even work better on a low-income setting, where maybe some of the issues like patient-provider communication is sometimes even better. If we talk about low-income setting, we could follow up patients either with phones, we could follow patients with smartphones. We know that even low-income setting are using smartphones in a very accelerated rate, and we could even use letters, pen and pencil to fill this out, like traditional ways. So it doesn't really have to use, some of these issues I was talking about, like EMR integration, are important. They are a way to bring this into the conversation. They're not the only way to bring this into the conversation. In a low-income setting where EMR is not part of the patient-provider conversation or patient portals, then it could come into this conversation through other means. And again, it's stressing out the importance and making sure it's part of the discussion with our patient. And that can be done on any level. And I thank you for that question. I think it's a very important one.
Thank you so much. That's going to be the last question for this session today. So we will finish our Q&A session with this last question. It's coming from Mary Cook, and she thanking you for this interesting presentation, and she would like you to comment on how we might measure outcomes for patients with Alzheimer's disease.
So again, it's as I've said, that there are a couple of conditions, like Alzheimer's is one of them, stroke is another where we had experience with at Boston. Even addressing pediatric populations, neonates or small children, where you're going to be needing a proxy to deliver the information. Many of the standardized tools have been validated for the use of proxies, and they have been used, again, mostly for research purposes, to be used by a proxy. And there are tools that have been designed for this, for Alzheimer's patients specifically. So I would use those tools. The rest of the program, in terms of how do you get the response rates, how do you reach out to patients or their caretakers, is going to be very similar. But the tools need to be ones that are used by the proxy, and the proxy is going to be filling this out on the patient's behalf. It has to be somebody that knows the patient, that is spending time with the patient for some of these answers to be given. But again, it's something that generally can be done, and there are very validated and standardized tools to be used for these purposes.
Thank you so much, Dr. Zimlichman, and thank you for your patience and for carrying on and delivering such a fantastic presentation despite all of the technical issues today. I would like to remind everybody that the recording of this webinar will be available on the ISQA website within 24 hours of the actual webinar taking place. So if you have somebody who would be interested in the information provided in this webinar, please pass this information to them. Would like to thank the audience for bearing with us today, for joining us for this session, and I would like to wish everybody a fantastic day. And once again, I would like to thank Dr. Zimlichman for doing such a fantastic work and for spending and sparing his time today for delivering such a fantastic session.
My pleasure. Thank you very much, Liana.
Thank you.